Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm talking today to Dr. Alex Krist, a family physician, a faculty member at Fairfax Family Medicine Residency Program, and also a Virginia Commonwealth University faculty member who directs their practice-based research network. Dr. Krist, thank you for joining with us this morning.
Thanks for talking with me, Larry.
So I learned last week that you have developed a model that provides guidance for people in primary care, family medicine, regarding how they should respond to the current epidemic that we're experiencing. Could I ask you to describe that for the people who are listening?
Well, let me just start by saying that I think it's unfair to say that I've developed a model. This is actually kind of emerged from our group of primary care practices that are really trying hard to respond to the pandemic right now. And we've been putting a bunch of teams in place to try and take care of our patients in our community. And we're trying to think forward about what's going to happen. And I think from these actions, this model emerged, and we're thinking about these different waves of what's going to happen to our patients and how we have to respond to it. So the first wave we thought of is what we're labeling the signal wave, and this is when we start seeing cases and people getting sick across multiple communities. I think everyone in the entire United States is finished with this signal wave. We've passed this. The second wave is the spread wave. This is as more and more people in our community start getting infected, and we start having to change how we're doing care. And I can talk about what we need to do in each of these waves in a second after I kind of outline them all.
Okay.
The third wave we're thinking of is the acute wave, and this is, people get sick and they're in the hospital, and we start seeing more and more people in the hospital, and we have to think about hospital care. And then the fourth wave we're thinking about is the convalescent wave. This is when patients in the hospital get better, but they've been sick, and they normally go to a rehab center, and they're normally going to need recovery, but there aren't rehab centers and there aren't places for them to go. And then the last wave we're thinking about is this consequence wave. And this is sort of everything that happens from this. This is the preventive care we should have done that we didn't do, and maybe some things have emerged. It's the chronic care that we haven't managed as well because we've been in these crises modes. It's people dealing with the social determinants of health. Now they're unemployed, they have financial risk, maybe they have issues with housing and all these other factors that we know impact people's health and their care. And it's all the worsening mental health and substance use that's going to occur from this. And that's the last wave. And all of these waves kind of happen together, we think, and they build on each other. And there's different things we're trying to do for each of these waves to take care of our patients and our communities.
So could you describe perhaps some of the detail involved in each one of those?
Yeah. So I think right now in Fairfax, Virginia, we're in this spread wave, and we're getting ready to move to the acute wave. There's some models that are out there that predict peaks in different communities, and the model I see is peaking a peak in our community for April 17th right now, and it's April 1st today. So I'm going to start with sort of that first wave, the signal wave. I think most of us were doing things like trying to only have people come in who needed to, trying to wear masks in the office, trying to have people sit 6 feet apart, maybe not having as many people in our waiting room, maybe having a sick waiting room and with people with respiratory illnesses and another space for people who are well. We're finished with that wave, and practices need to be beyond that. The spread wave, we're thinking that there's 3 things that need to happen, and we've already really done those. So one is convert to complete virtual care. So our group of practices saw 9,000 patients a week. First 3 weeks of March, zero point 0.7 of those were virtual. The week after that, we went to 45%. And now we're pushing 99%. And people are only coming in after they're being triaged through a virtual visit, and they must be seen. The second thing that we're trying to do in the spread phase is implement proactive population care. So we're trying to put together lists of our patients who are vulnerable, meaning the patients who are at risk for getting coronavirus, also our patients at risk for having worsening chronic condition, and also our patients who are at risk for having worse mental health and social risk. And we're trying to reach out to these folks and contact them and talk with them and let them know that we're here to help them and to find out what they need. And then the third thing we're trying to do in the spread phase is to protect our patients, our emergency rooms, and our hospitals. So by being there virtually and by being that first contact with patients, we can have the folks who have respiratory infections, who are worried, and may or may not have coronavirus. We can take care of them at home and we can reassure them. And the patients who we know have coronavirus, who we're seeing, if there are safe testing centers, maybe we can get them to those. And if there aren't, we can manage them at home and let them know when they need to hit the emergency room in the hospital system. And we can even try to do a version of virtual hospital care. That leads into the acute wave. And what we're thinking about, we haven't really hit this yet in Virginia, but we're getting ready to. And what we're thinking we need to be doing in this acute wave is doing things like virtual home hospital care. We know that our hospital is going to fill up and there aren't going to be enough patients or beds for our patients. Our group of practices cares for 200,000 patients in Fairfax County. And at any point in time, we have about 15 to 30 patients on our hospital service. So if 10% of our patients get coronavirus, that's 20,000 of them will get coronavirus. And if 15% need to be hospitalized, that means we're going to have a service of 1,300 patients. That's orders of magnitude more than we care for, and there aren't that many beds in our hospital. So we're trying to put together virtual hospital services for patients at home. These are the patients who we normally put in the hospital, but there aren't beds, and we think we can manage them at home. We're going to try to check in with them virtually every day. We're going to try to figure out if they need some home services, whether it's antibiotics or maybe oxygen or other things. And we're also going to be thinking about the patients who really wouldn't want to be on ventilators and who have things like DNRs and DNIs. And we're going to try to be able to do good home palliative care. And I think that can help our patients, protect our hospitals, and help our community. And also in that acute phase, we're trying to figure out how do we staff our hospitals? You know, where are we going to best be able to work with our health system and do the services that can provide? So we staff 2 hospitals. One's a bigger academic hospital. There's 130 different residents there. The other hospital is a community hospital. We're the only residents that are there. And we're really pulling all of our resources and focusing on that community hospital. And we've done this in a coordinated way with our health system so that the other residents and other specialists can staff that one larger academic hospital, and we can help this community hospital that we think is going to get overwhelmed. The next wave that we're thinking about, that convalescent wave, and as I said, a lot of these patients, when they're in the hospital and they get sick, when they get better, they're not going to be able to go home. They normally go to a rehab center, but we know that there aren't going to be beds and rehab centers that can take them. Even if these centers did take them, they would overwhelm the centers that we have. But many of the centers are going to be scared to take them because they don't want to infect other residents. So we're trying to start thinking about how can we do that home rehab type work? And we're trying to partner with our health system to try and think about how can we set up other places that they may be able to go to, whether it's in churches or schools or other buildings that aren't being used right now. And if we don't deal with that convalescent phase, people are going to sit in the hospital, and that's going to back things up and make the acutely ill patients not be able to get into the hospital. Lastly, thinking about the consequence phase, we're trying to start to be proactive now, even though we really haven't hit this. And, you know, we're reaching out to our patients who do have, that we know have difficulties with mental health, alcohol misuse, other types of things, and trying to make sure that they feel connected. and that they're able to get into support and services that they need. Things like virtual cognitive behavioral therapy, virtual AA meetings, whatever it may be. We're trying to partner with some of our community organizations. So a church reached out to us because they wanted to help in the hospital. But I'm not sure that the church members are going to be able to do much in the hospital, but they can do a heck of a lot to help our patients who are trying to manage at home. They can do grocery shopping and getting essential supplies for people and bringing it to them and leaving it at their doorstep. They can make food for them. So we're trying to create these community partnerships with our practices so that we can start addressing some of these social needs that we know our patients are going to have. And then we're going to try to really think about how do we proactively ramp up the preventive services as the pandemic is kind of slowing down, hopefully in the next couple of months, to be able to really address and think about proactively these consequences that everyone's having to deal with.
So I have to say just how impressed I am with the breadth and depth of your team's thinking. So one of the questions that I have is I can't imagine that insurance companies are willing to pay for some of these services. I mean, you would think they would, but I don't even know if there are billing codes for some of these things. What's your thought? Because I know in many family practice offices across the country, they're getting slammed financially right now, and many are actually worried about going out of business. So what's your thought about all of the financial issues?
Well, I share those worries. I mean, I'll tell you that our physicians all cut their pay dramatically right at the start of this, and we were hoping to not let staff go or in trying to keep everyone on and employed as best as we can. And a lot of our staff has actually agreed to reduced hours and reduced pay to try and deal with this. And I'm just going to say right now, I think this is criminal because everyone is working harder than ever. And we're hearing things like some of our insurance companies not wanting to pay for some of the virtual visits and population health care that we're providing. Now, all that being said and putting that aside, the two things I want to say is that I think that everyone is really trying to work together to try and make things work. We know that CMS is paying for virtual visits and they're paying for telephone care. I hope that the insurance companies will follow suit. And I think as a profession, when we're done with this, the insurance companies that don't follow suit, we should call them out publicly. It needs to be acknowledged what they did or didn't do to help with the epidemic. But I think there are ways to be reimbursed for this. And, I'll also go on to say that our practice, we've always been here for the community. And
Alex, I think you're beginning to break up.
I'm sorry about that. We've always been here for the community, and we just believe that this is our job to do this and to help people. And so I think that's what we're focusing on.
Well, I want to commend you and would really like to give you a big hug for what you and the rest of your crew are doing. Dr. Michael Fine, a family physician in Rhode Island, talks about the public purpose of primary care, and it's something that's not been articulated well nor supported well. And I think what you're describing here is just the way you think and the way that you are developing your services and supporting your community really does reflect the public purpose of primary care. If you're able to respond to your patients and your community in the way that you're describing, the pressure on the hospitals and the pressure on those critical ventilators and ICU beds will be significantly reduced. You want to comment on that?
Yeah, I think that's that's exactly what we're trying to do, and I think that that's a great observation. And what I would say, a silver lining with all of this is that this pandemic is, I mean, it's transformative for primary care. I mean, it's transformative for everyone across our country and throughout the world. But if we're able to hold on to some of the things that we're doing, if we're able to really kind of enter the digital age and be able to digitally provide services for patients and to increase the accessibility and change how we're working with people and do the type of population health that was, really envisioned when the old patient-centered medical home was created, those concepts back in 2004. We've never really seen realized the way we know as family physicians they should be. And so here's an opportunity where we have to make massive changes in weeks. And these massive changes are going to make us better. They're really going to combine the relationship, the personal touch, the family medicine principles with public health, with proactive care, with the informatics that we've always argued needs to be there in place, the partnerships with communities, community organizations that we've always wanted to develop. These things are happening, and I think there's like new calls for us to keep these in place and to make our profession really be able to move forward into the next century in a way that we can help people in communities that we've never done before.
So I would just like to finish up just by once again saying how impressed I am. When I think of the vision of the founders of family medicine and how it would play in a crisis like this, you and your team are a perfect example. You're an exemplar, and I'm hoping through this broadcast that we can share this broadly. And I think that I've been talking with a lot of people across the country. I think other primary care practices are trying to serve their patients and their communities in the ways that you're talking about. I think you've articulated a model that will help them to think through not only the immediate situation, but what's to follow.
Yeah, and I couldn't be prouder of our primary care practices. Just looking throughout Virginia and our network, we've talked here about what our group is doing, but I'm seeing so many practices do the same to make all these changes, and I couldn't be prouder of primary care and family medicine right now.
So, Dr. Krist, I want to thank you for sharing your model and sharing what you're doing. And if there's anything the Family Medicine Education Consortium can do, please look at us as an ally and a supporter. And I want to thank you very much.
Thank you, Larry.